Hello everyone, this is Vaishak from PhysioBrainary. In this video, I'm going to explain in detail about fracture classification. So coming to the introduction, what is a fracture? A fracture is a break in the continuity of a bone, either across its cortex or through its articular surface. Or in simple terms, fracture is a disruption of the normal architecture of the bone. And coming to the open fracture, a fracture with break in the overlying skin and soft tissues leading to the fracture communicating with the external environment is known as open fracture. A fracture may be open from within or outside, the so-called internally or externally open fractures respectively. So what is internally open fractures? That is from within. The sharp fracture and pierces the skin from within, resulting in an open fracture. That is known as internally open fracture. And externally open fracture, by the name itself you can able to understand that is open from outside due to some objects. The objects causing the fracture lacerates the skin and soft tissues over the bone as it breaks the bone, resulting in an open fracture. Exposure of an open fracture to the external environment makes it prone to infections. This risk is more in externally open fractures. The risk of or prone to infection is more commonly in externally open fractures comparing to the internally open fracture. And coming to the classification, the main classifications of different types of fractures are Gustilo Anderson classification, which was put forward by Dr. Ramon Gustilo and Anderson in 1976. This is the Dr. Ramon Gustilo from Philippines. And next classification, there was a modification in this Gustilo Anderson classification, same which was put forward by Dr. Gustilo, Mendoza and Williams in Journal of Trauma in 1984. And the next classification, there are so many classifications. Apart from this, the latest classification and the revised classification is known as AO classification, which was put forward in the journal in 1996 and which was revised in 2018. This is the AO or OTA classification. And coming to the first classification, that is Gustilo and Anderson classification. The Gustilo-Anderson classification divides the soft tissue wounding of open fractures into three grades. That is grade 1, grade 2 and grade 3. And the grade 1 or type 1 is wound is less than 1 centimeter in size. It is usually due to low velocity trauma. And the type 2 or grade 2 is wound is more than 1 centimeter and less than 10 centimeter, but there is no devitalization of soft tissues and is associated with very little contamination. These are due to high energy trauma. And the last classification is type 3 or grade 3 classification, in which the wounds will be moderate and severe in size, that is greater than 10 centimeter, and the soft tissues are devitalized and contaminated. So grade 1, the wound will be less than 1 centimeter in size, and that is low velocity trauma. And grade 2 is more than 1 centimeter and less than 10 centimeter in size, and there will be very little contamination and it occurs due to high energy trauma. And grade 3 is moderate wound and severe in size, that is greater than 10 centimeter in size, and the soft tissues are devitalized and contaminated. So these are the Gustilo and Anderson classification. And next is the diagrammatic representation of the Gustilo and Anderson classification. So you can see here type 1, that is skin wound less than 1 centimeter, it will be clean and not contaminated, and that is occurring due to low energy trauma, and this is will be a simple fracture pattern. And grade 2 or type 2 is skin wound more than 1 centimeter but less than 10 centimeter, and the soft tissue damage is not extensive, no flaps or avulsions, simple fracture pattern. So this occur due to a moderate force. And next grade or type 3 is a high energy involving extensive soft tissue damage, more multifragmentary fracture, segmental fractures or bone loss irrespective of the size of the skin wound. It occurs due to severe crush injuries and vascular injuries is there, so that would require a repair, and severe contamination including farmyard injuries. So this is a severe high velocity trauma. So this will be a moderate to high velocity trauma, and this is a low energy or low impact trauma, grade type 1. So this is the diagrammatic representation of grade 1, and this is the grade 2. So grade 1 will be less than 1 centimeter. Grade 2 is more than 1 centimeter but less than 10 centimeter in size, and grade 3 is more than 10 centimeter in size. So grade 3 is the severe form of injury according to the Gustilo and Anderson classification of open fracture. So no classification invites so much of debate as for open fractures, with only 60% of the surgeons across the globe accepting it. Hence, newer modifications are now being suggested, like the modified Gustilo-Anderson classification, the Trafton classification that combines the Gustilo-Anderson classification and Schern's classification, And the latest, that is the revised in 2018, that is the AO or OTA classification of soft tissue injury with alphanumeric classification of fractures. The second classification is the modified Gustilo-Anderson classification that was put forward by Gustilo, Mendoza, and Williams in the Journal of Orthotrauma in 1984. In this, there is a modification. Only modification is the subclassification or subdivision of the type 3. In normal Gustilo-Anderson classification, it is type 1, type 2, and type 3. And in modified Gustilo-Anderson classification, they had further subdivided the third grade of Gustilo-Anderson classification into a subdivision, that is 3A, 3B, and 3C. So first one is type 3A, that is an extensive soft tissue injury but with adequate soft tissues to cover the fractured bone. Type 3B, that is an extensive soft tissue damage and loss. Bone cannot be covered and is exposed to the atmosphere. And type 3C is a compound fracture with the arterial injuries. So this is the modification of the normal Gustilo-Anderson classification in 1984, which was published in Journal of Trauma in 1984 by Gustilo, Mendoza, and Williams. So they had divided the third grade of the normal Gustilo-Anderson classification in 1976, and they are further subdivided into type 3A, type 3B, and type 3C. So this is the diagrammatic representations of the modified Gustilo-Anderson classification. In this, type 3A, adequate soft tissue cover of bone despite extensive soft tissue damage. Type 3B is extensive soft tissue injury with periosteal stripping and bone exposure. Major wound contamination occurred. And type 3C, that is a compound fracture or open fracture with arterial injury which requires a repair. So this is the classification or diagrammatic representation of the Gustilo-Anderson classification and modified Gustilo-Anderson classification. This is the type 1 fracture, which is less than 1 centimeter in size. Second is the type 2 fracture, which is less than 10 centimeter size and but greater than 1 centimeter size. And type C or type 3, that is the this is the type 3, again classified into type 3A, type 3B, and type 3C. This is the modified Gustilo-Anderson classification. And this is the type 3A, and this is the type 3B, and this is the type 3C. This is the again, this is the modified Gustilo-Anderson classification of open fractures. Next classification is the AO classification or OTA classification. The AO Foundation or Orthopedic Trauma Association, that is the OTA fracture classification, was published as a compendium to the Journal of Orthopedic Trauma in 1996. Using the principles of comprehensive classification of fractures of the long bones developed by Muller and collaborators, the OTA classification committee classified and coded the remaining bones. This helped bring order to the state of fracture classification with its multiple systems that has thwarted any possibility of a standardized language and accumulation of uniform data. The AO classification of fracture wound severity provides a grading system for injuries of each of the skin, that is I, muscles and tendons, MT, and neurovascular, that is NV, each of which is subdivided into 5 degrees of severity, that is from IO1 to IO5, that is for skin, and MT1 to MT5, that is for muscles and tendons, and NV1 to NV5, that is neurovascular. So this is the subdivision or subclassifications of AO classification for each structures. That is the skin for I1, I2, I3, I4, I5, and muscles and tendons MT1, MT2, MT3, MT4, and MT5, and neurovascular, that is NV1, NV2, NV3, NV4, and NV5. And it is designed to provide a unique, unequivocal definition of an injury and thereby allows accurate comparison of cases. So coming to the determination of morphology of a fracture, the morphology of a fracture is described by precise definitions, allowing the surgeons to determine the type, group, and subgroup. The fracture of each bone segmented are divided into 3 types, that is type A, type B, and type C, with a further subdivision into groups, that is group 1, group 2, and group 3, and their subgroups, that is 0.1, 0.2, and 0.3, generating a hierarchical organization. So coming to the types, the descriptions of the type differ from between diaphyseal fractures and proximal or distal and segment fractures. These descriptions of fracture types are coded with A, B, and C. The 3 fracture types in the diaphyseal segment are simple fracture, that is one fracture line, cortical contact between fragments exceeds 90% after reduction. Next type in the diaphyseal segment is the wedge fracture, in which 3 or more main fragments have contact after reduction. Next type, third type, is the multi-fragmental fracture, in which the main fragments have no contact after reductions. These are the three fracture types in the diaphyseal segment. The three fracture types in the proximal and distal end segments are extra-articular fracture, that is the first type, in which no involvement of displaced fractures that extend into the articular surface. Next is the second type is the partial articular fracture, in which the part of the articular component is involved, leaving the other part attached to the metaphysis or diaphysis. The third type is the complete articular fracture, in which the articular surface is involved. The metaphyseal fracture completely separates the articular component from the diaphysis. These are the three fracture types that occurs in the proximal and distal segments. That is the extra-articular fracture, partial articular fracture, and complete articular fracture. So the types has been finished, and coming to the groups and subgroups of a fracture. So once a fracture, whatever its bone segment, has been recognized as one of the three fracture types, it may be further divided into three fracture groups, that is group 1, group 2, and group 3. For diaphyseal fractures, the fracture groups are type A, that is simple fracture, that is spiral, oblique, and transverse. And type B, that is wedge fracture, intact, and fragmentary. And type C, that is multifragmentary fracture, that includes the intact segmental and fragmentary segmental, type 2 and type 3. So the fracture groups in the fractures in the proximal or distal segments are type A, that is extra-articular fracture, that includes the subtypes, that is simple, wedge, and multifragmentary, type 1, type 2, and type 3. And type B, that is the particular articular fracture. The groups may be variable depending upon the bone. And type C, that is complete articular, in which the simple articular, simple metaphyseal, simple articular, multifragmentary metaphyseal, multifragmentary articular, and metaphyseal. So simple articular, simple metaphyseal is the type 1, and simple articular, multifragmentary metaphyseal is the type 2, and multifragmentary articular and metaphyseal is the type 3. For more specialized requirements, these groups are further subdivided into subgroups either based on the fracture location or fracture site morphology. More detailed information concerning the fracture morphology may be added using the qualifications and universal modifiers. So coming to the alphanumeric structure of AO or OTA fracture and dislocation classification of long bones. So this will be diagnosed by X-ray, CT, MRI as required. And based on the localization, first is the bone, then comes your location. Based on the morphology, first comes your type, then group, then further that is subgroup, and next is the qualifiers or qualifications, and next is the universal modifiers. So qualifications will be provided or applied in the rounded brackets, and universal modifiers will be added in the square brackets. This is how you will be categorizing the classifications according to AO or OTA fracture and dislocation classifications for long bones. So for example, humerus, proximal end segment, articular or four-part fracture, that is valgus impacted and both tuberosities fractured. So in this, you can see here, the bone is the humerus, that is the type 1. So bone is the humerus, that is the type 1, and the segment, that is the proximal. So proximal segment, you can see here, 1. This is the proximal segment. So since it is proximal, the segment, the number or numerical system is 1. And type C or type, that is C, that is because of the articular or four-part. Since it's a four-part or articular fracture, we will be mentioning it as type C. And group, this is actually 1. So since there is a fracture only occurring in the anatomical neck, so this is actually 1. This is a mistake. So this will be 3, in which the anatomical neck fracture associated with metaphyseal fracture. If it is an anatomical neck fracture associated with a metaphyseal fracture, then it will be grouped under 3. So this is since this is only anatomical neck fracture, so this will be coming under group 1. So this is C1. So C1. This is not 3. This is C1. And subgroup, that is valgus impacted. Since it is valgus impacted, so this will be subgrouped as 1. That is 0.1. So this is a mistake. So 0.1 because so this is an intra-articular in which both tuberosities is fractured. So valgus impacted with multifragmentary metaphyseal segment involved and with intra-articular fracture. So intra-articular surface. So this will be C1.1. So 0.1 will be the subgroup, and qualification, since it is a valgus impacted over the greater tuberosities as well as the lesser tuberosities. So both tuberosities is involved. So because of the both tuberosities getting fractured, so this is known as P. Otherwise, it will be N or O, depending upon which tuberosities which is getting fractured, either the greater tuberosity or the lesser tuberosity. So this is P because both tuberosities is fractured. That is and valgus impactor. So this is a qualification. This will be putting forward in a bracket. So next is the universal modifier, that is 5A. So since this is a anterior dislocation occurring, so this is comes under the 5A category. So that is 5A, that will be mentioning in the square bracket. So this is how you will be categorizing the fracture according to the AO or OTA classifications. So this is all about the fracture classification. Different fracture classifications came from the Gustilo-Anderson classification from 1976, then to the modified Gustilo-Anderson classification in 1984, then comes to the 1996 AO or OTA classification, which was again revised in 2018. So AO or OTA classifications. This is all about the fracture classifications, and this is an important question in the clinical ortho for your physiotherapy students in the clinical ortho subject, and it either comes as a 5 marks or a 20 marks question. So what is the different classification of fractures or open fractures? So this is all about the fracture classification, different fracture classifications. And thank you for watching this video. Please do subscribe this channel and share this video to your physio friends and fraternity. Thank you.